All right, great. All right, welcome everybody. Thank you so much for joining us today for this update with Reverend Keith Goheen on update on advanced healthcare directives and changes in the Delaware law. We are live streaming this on Facebook as well. Um, you're welcome to ask questions throughout. At the end of the session, we will end the live stream and end the recording. So if you had any questions that are a little more personal, you're welcome to hold those to the end, and we will have some time where we will not be recording and live streaming. And at this point, I will turn it over to Reverend Keith.
Again, thank you. Welcome, everyone. I'm glad that you are here with us this afternoon. I'm glad you have brought your curiosity with you this afternoon. I'm Keith Goheen. I'm the lead chaplain at BB Healthcare, and I also co-chair the hospital's bioethics committee, which is one of the places where I started getting involved with advanced healthcare directives. I'm a 20-year veteran with BB, and much of that time was spent in our intensive care unit, which is a place where advanced healthcare directives really become important. So I've got a lot of experience in interpreting them as well. I'm going to be welcoming your questions as we go through here today. 2025 was a busy year for the Delaware legislature, and among other things, they updated a lot of their statutes around end-of-life care issues, which means that I've been doing a lot of policy writing this year, and also needed to update our advanced directives. The good news, in case you were wondering, if you already have an advanced healthcare directive, it is still valid. And you're looking at what we're doing today. If you would like to update, certainly you can do that. So I think we'll go ahead and start with the presentation, if that's all right with you, Kate. And does everybody see the Advanced Healthcare Directive screen?
Yes.
Okay. I chose these pictures at the top because an advanced healthcare directive is really kind of a conversation with your healthcare team, something that you would fill out in advance so that should the time come, should the need arise where you need to make significant decisions about your healthcare, but you can't tell us, this directive becomes an important guide to understand what you would want, what you would tell us if you could. So when you're looking at your advanced directive, when you're thinking about it, filling it out, what you're really doing is writing in there what you would want your doctor to know at the bedside to deliver your care. And of course, this is a vertical document and a horizontal screen, so we'll do a bit of scrolling here. The very first page is one in which we name the power of attorney for healthcare, the decision maker, or sometimes they use the word surrogate decision maker to talk about who that person would be. Obviously, for your doctors, if you're in the hospital and for whatever reason you can't tell us what you may or may not want, we want to know who you would like to do that. The state of Delaware produces a sort of hierarchical list of people if no one has been indicated. If you've filled out this part of the form, the power of attorney form, that is the person who legally has the authority to make the decision for you. And it could be anyone whom you would like it to be. We strongly recommend that it is somebody who knows you well and someone who is committed to carrying out your decisions, because really their task isn't so much to decide what they want for you, it's to decide or to make sure that the staff is doing what you would want. In addition to designating an agent, we strongly recommend that you have an alternate agent, a second person who can step into that role if the first person isn't available for whatever reason. A couple of years back, for example, we had a couple and they had each other as their decision maker, which, by law is the default. They ended up in a rather bad car accident. Neither one was available, so we had to go digging to find someone else. If we have an alternate agent available, it gives us and gives you some flexibility to make sure that we have the right person there to be making your decisions for you. When does this go into effect? This goes into effect anytime. Actually, there are two parts here that go into effect. Um, the main document goes into effect anytime that you're unable to make decisions for yourself. It may be that you can't physically talk to us, or it may be that perhaps you are not capable of making clear decisions right now. Someone, for example, with a severe infection who can talk, but maybe really doesn't understand what's going on. Um, or someone with an advanced dementia who, again, would not be able to comprehend the questions that are being asked. And so I just realized there's a misspelling in that. Agents misspelled. Oh my goodness. Sorry for the sidetrack. Anyway, so this goes into effect when you can't tell us what you would like to have. And I'm going to pause there for just a second and see if there are any questions around agents. All right. I just realized I took my headphones off, which means I need to put my hearing aids back in.
Did someone have a question, or was that just background talking?
All right, I'll go ahead and move along. We can pick up more questions later.
Yeah, I think that's fine.
This next part two, instructions for healthcare, is a series of general questions, and this would go into effect anytime that you're unable to tell us what you would want. And it gives us really some values or some general goals to talk about what you may or may not want to accomplish with your health care. And as you can see, there are a number of different options in here. For example, on this first one, the question is on staying alive as long as possible, even if I have substantial physical limitations. Is that something that would be important to you? Is it something that, well, maybe your decision maker needs to weigh that with the staff? Or is it something that's really not a priority for you? Um, Substantial physical limitations could be something like the potential for being a bedbound patient. For some people, that would be a quality of life that would be unacceptable to them. For others, it would be more important that they keep trying. And so you could give us that little bit of ranking, whether doing everything that we can to stay alive would be very important, somewhat, or not important. If there was a risk of a substantial mental limitation, um, how aggressively, to put this in a little different way, how aggressively would you want the staff to treat you to try to um, get as much recovery possibility for you as they could? Um, Again, would recovery be very important, somewhat important, not important if you were facing the difficulty of having substantial limitations? Uh, what might that be? Well, I'm thinking here, for example, of someone who's had a very significant stroke and for whom the likelihood of recovery, of getting back to where they were, would either be very limited or perhaps really not a possibility. Would you want us to continue doing things that would maintain your life at that point? Um, Kind of heavy topics, but important things to think about. What about being free from pain? Many of our um, patients, of course, are very much in a mind of, yes, I want my pain managed. And certainly we can make that a goal. But some folks have concerns about that and different kinds of pain medications. Here's a place where you can let us know. Being independent is another question that comes up here. And by being independent, I'm thinking, being able to move around the house, or really you would define that? Would you be able to still go grocery shopping? What level of independence would be important? These, by the way, would be great conversations to have with your decision makers when you're filling this out or after you fill this out, to give them more detailed examples of the kinds of things that um, would help guide them in the decision-making process. Would you like your agent to be in conversation with your family around care decisions? This is a place where maybe you would like your agent to consult with your children, or maybe a sibling, someone else with whom you're close who also knows your values well. Maybe you would prefer that the agent would really, they're the person who needs to make the decision. So if you wanted them to talk to family, that would be a very important thing. If you really want your agent to be kind of the sole decision maker, then that's a not important. And having my agent talk with friends is also an option here. Again, for the same reasons. Would you rather the decision about your care be made kind of collectively, and some families work very well collectively, some don't? Or would you rather that your agent really takes the lead? There's a space here at the bottom of the page for some additional priorities. If there are other things that you would want to write in that you would think important in this area, this would be a good place to include those things. And I'm going to pause here for just a second, kind of scroll back a little bit, and see if there are any questions around healthcare priorities.
Right. I think she is.
Yes, Dorothy?
Would you list like concerns for not being put on any machines or anything under those other priorities, or is there another part that gets more specific in this document?
No, that's a good question. And yes, I think it would be very appropriate to put down here in other priorities. You could say something along the lines of, I would prefer to avoid placed on a breathing machine. You could say here, absolutely, I wouldn't want that. Um, Again, these are in a broad, what's what I'm looking for here? Um, this is the broader questions about your care, but absolutely, if that were a priority for you, if that was something you really wanted to avoid, you could put that into other priorities.
And is the term that you would use like asking for no extraordinary intervention, is that the proper language, or is there a certain term that's understood to include
You
like,
could do that, no extraordinary.
I wasn't sure what the language was, but
Okay.
to include like, intubation, or, putting not just intubation, but being put on a machine for extended time and all.
Uh-huh.
Um,
Yeah, I don't know, need to get the language exactly precise, but if we know what the spirit is,
mhm.
one of the terms we sometimes use in healthcare is no heroic measures.
Okay.
Thank you. Other questions?
Nina?
Yeah, I just wanted to say, Reverend Keith, I'm thrilled that you're here and that you're doing this. I sat on the ethics committee at Christiana Care for several years, and using those kinds of blanket terms leads, in many cases, to an ethics consult. It's better to be very specific about what you do and don't want, because everyone's going to interpret extraordinary measures in a different way. I mean, every doctor is going to interpret that differently.
That's
So
true.
for someone who has really strong feelings, I would recommend being specific.
All right, thank you. And you can certainly consult with your doctor about what kind of language you would they would recommend documented. And this is one of the things where our palliative care teams are really, really helpful for those of you who may be involved in palliative care programs. Other questions, comments? This is a new section, by the way, in the advanced directives for those of you who haven't seen them before, and I really think it's helpful because it helps fill in the broader picture. Aware of no other questions, I'll go ahead and move on to the next one. Now, these are specific questions about life-sustaining treatment. And Nina, maybe this goes a little bit to what you're talking about too. These go into effect in a very specific situation. And when you almost use the word case there, I should say situation. And by that, I mean these instructions go into effect when your physician determines that it's very unlikely that you're going to recover. And you'll see that in the language as we go through here. Life-sustaining treatment is any treatment attempting to keep me alive, but not needed for comfort or for any other purpose. That means there's nothing healing involved in it. This is like being on a respirator, for example. It helps you breathe, but it doesn't cure whatever it was that is causing the problem. These treatments can include, but not limited to, cardiopulmonary resuscitation, CPR, the use of a breathing machine. Kidney dialysis could be considered here as well, because kidney dialysis, of course, doesn't make the kidneys better, it simply filters your blood. And if you were in a situation where you were very likely not to recover, would you still want to have your life sustained for, as again, that would be a conversation that we would have with your agent, with your decision maker. And you can indicate here, as you can see, under which conditions you may or may not want to receive that. The first one, it says, always given to me. If you're a person who is, sometimes the language they use is they're a fighter, and you want everything done, that's the box that you want to check. But if you have a condition that is not curable and is expected to bring death fairly soon, again, that would be a decision that your doctor would make, and that's kind of, I think, Nina, what you were referring to. There's a box that you would check. If I were unconscious and not expected to be conscious again, the old language here was permanent unconsciousness. I think this gets a little bit at it a little bit better. If it's very unlikely that you're going to wake up from whatever injury or illness that you had, would you want us to continue sustaining your life? And of course, on the third one here, where you're not expected to recover, and it prevents me from communicating with people I care about, caring for myself, or recognizing family or friends. If you weren't able to effectively interact with others, would you want us to continue? And then there's some space here also for other considerations that you might want to put in were you at the end of your life. Would you like to receive food and liquids? And again, there are a number of conditions to be considered. And food and liquids here would be where you would need to be fed, usually through a tube. And as this says, for the rest of my life. So we'd be looking at something that wouldn't be given to you just to get you, strengthen you for a couple of days and get you back. This would be something that would have to sustain for a while. Where an item like this can become important. For example, with a patient with advanced Parkinson's disease, because eventually Parkinson's inhibits the ability to swallow. in the advanced stages. And if you got to that point, would you want artificial nutrition through a tube? Um, Difficult questions to ask, but nonetheless something important that to be considered. And many people have concerns around discomfort there, but any discomfort, should you choose not to, um, if you choose not to use this option, could be managed with medications. And I'm going to pause there for a second. Questions?
Dorothy?
Sorry, I keep muting myself. In either question where you check, if you check always, and so those things are given to you to sustain life. Does that mean that the medical staff, the hospital, will not reverse that? So if it's given to you, then does it have to stay, you have to stay on the machine regardless, or you have to stay on the feeding tube regardless of if your condition gets worse or if it's possible to get worse?
Yeah, I hear you. Um, yeah, the staff would read this as an instruction to keep you on whatever support they have you on as long as you need it. Now, if for some reason, you were able to recover to breathe on your own, say from a stroke, then maybe it could be withdrawn, but it wouldn't be withdrawn as long as it was medically indicated.
What
Now,
if your agent knew that you didn't want to be on it forever? You didn't want to just lay there for months on being intubated or on a feeding tube. Would
uh
that agent be able to give the direction to take you off?
um, at some point, staff may need to go to your agent. Um, if you had indicated always given to me, they would be very reticent to withdraw it unless there was a high level of confidence that you were in fact actively dying. They would not maintain it in the dying process.
Okay.
But you would have to be very deconditioned, I would think, too, before that conversation comes into play. Do you follow me?
Yes. Yes. Thank you.
You're welcome. Using the always option, typically someone who chooses that option never gets well enough to go back home. So if they were able to leave the hospital, it is likely that they would be transferred to a long-term care facility. And there are only two on the peninsula that are able to handle respirators at this time. So that it's a sort of a background piece, something else to consider. Um, Other questions? All right, we will roll on. You can give us an indication about your preferences for relief from pain. Now, I'm a bit of a pain coward, so I'm in the always category there. But this can be an important question. I know some folks have concerns about addiction and things like that. So you have that liberty here to let us know how you would want us to handle your pain. And I'll just pause for a second for a quick questions if there are any. The legislature has added some optional special powers and guidance. And these only go into effect if you indicate that you specifically want those in place. Um, Admission to a mental health facility, admission to a nursing home for more than 100 days, which generally is considered long-term placement as opposed to rehab. And you'll note that the option there is that even if it can be met somewhere else. Right now, an agent, if this is not checked, your agent couldn't commit you to long-term care if it was possible that you could be brought home and cared for at home. This would give them the option to do that. And then also the sharing of information. This allows your agent to have your medical information earlier than it used to. If you were still, for example, your agent could help you in decision making. If you had the capacity to decide but was kind of struggling, um, you could essentially use your agent as a consultant with you in the decision-making process. In the past, they couldn't have access to that information. Or maybe you have limited decision-making capability and there's some bigger questions that they could kind of help work through with you. And then maybe to go back to that earlier question, you can give your agent permission to be flexible in applying these instructions if it thinks it would be in my best interest. And I think that goes specifically to even if you checked everything and, a month later we're coming back around and your agent might say, this really wasn't what she had in mind. So maybe we need to reconsider this. Depending on your relationship with your agent, I think this is a really helpful tool if it's really someone that you trust and knows you well. Questions on that? This last section is just some spaces for you to write in things that you might not have felt got covered anywhere else, but your doctors need to know that. Under additional instructions for my medical care, maybe you have concerns about the use of blood products, or maybe you wouldn't want any major surgeries. Things like that could go in there. Goals of care are more about quality of life and values uh, that you would hope could be achieved with the support of the medical care that are being offered. And if those goals couldn't be met, maybe your goal is to live to be 100. Go for it. Put it in there. And then here's a place for personal needs and values. And really, the person that inspired me here for this one asked that she was especially concerned in ICU that she be given care, that her hair be brushed, and that she be made, not her words, these are my words, as presentable as possible. But it was important to her that she be carefully bathed and groomed. That was a value for her, and good, that needs to be there, and nursing especially would need to know that. Some general information for agents, some advice on how to be a good agent, essentially. Uh, This reiterates what I had said earlier. The agent's priority, the agent's objective, their task is to really be your voice. And for some people, it's going to be hard for them to think about you when it's difficult for them. One of the docs I worked with for many years had three daughters, and two of those daughters were designated as decision makers, and the third was specifically told no. He said, I know her, and she would never let me go. And he had already had a talk with the family, and they all knew that, and everybody was okay with it. But um, you want to make sure you have an agent who's going to be your advocate. To make the whole shebang legal, you only need one witness now. This is a change. The old system required two, and the list of who can be a witness is much broader than what it used to be. It's much more open than what it used to be, making this document much more easy to legalize. Your information goes at the top. Your witness information goes underneath that. The witness can be anyone other than the person you're designating as your agent and your alternate agent. So another family member, a neighbor, um, uh, BB healthcare staff does not witness these out of concerns that it could be regarded as a conflict of interest because we're also your care provider. So we would decline if you ask us. This is what the witness agrees to. I note here also that I was a bit too broad when I said who could witness it, because it does say that the spouse, domestic partner, or cohabitant, and cohabitant is a person who lives in your home for, has lived in your home for continuously for more than 1 year. They're also barred. Potential conflict of interest, I guess. There is an option to have your signatures witnessed. It's not required by the law. Many people find it helpful to do that. And again, the notary is only witnessing the signatures. The notary is not actually a witness to the document. And questions?
Yes, sir. An employee may not witness, may a volunteer witness, or does it have to be someone not related to the place of their healthcare residence at all?
Good question, Melanie. No, volunteers, at least from within BB's policy, volunteers cannot do that either because they are considered part of the team. They're not prohibited by law. I don't know what other institutions may feel around that, but for BB, witnesses cannot volunteer or cannot witness. Volunteers cannot witness. Did I say that right?
Yeah. Volunteers associated with the healthcare facility where the person is currently resting may not.
Correct.
Okay. But that may not be true in every institution. So Pete, you should check wherever you are at the time.
Yep, and that's good advice.
Okay.
Now, if your neighbor is a BB volunteer, I could go back and research this, but I think that would probably be fine if you walked across the yard and had them sign it. We can't ask them in the hospital to do that if that's where we were completing it. Subtle difference there in their roles, but
But that makes sense.
yeah.
Should I ask my question?
Sure.
Yeah, okay. So I don't remember earlier that the alternate agent that was listed by name. So do you have to do one of these for each? For, the agent and then the alternate agent too, since you're signing, giving directions or whatever, or how do you add the alternate agent's name to this document?
That would be back on page 1. I'm going to skip up there. Sorry, everybody, if this feels a little dizzying.
Was there a place for oh, I'm sorry. I apologize. I didn't remember that there was a space. Okay. And then
No,
I have another question.
okay.
I've had, an advanced directive that my church, I got through my church, but it's been a while, and this is so much more direct, plus it's updated. Can we access this form? Are you going to make that available for us to print out or?
We sure can. I can make sure that Kate has copies. You can drop by the hospital. We have this available on our website.
Okay.
If you go to bbhealthcare.org and put into the search advanced directive, it'll take you to the page where you can download this.
Okay, great.
And I can send it out in an email to everyone here tomorrow with a link to the recording of this as well, if you wanted to rewatch anything here.
Okay.
Awesome. Thank you. For those of you who are BB patients and have um, your, now I've forgotten the name of it, My Chart, which connects you to our Epic
Hmm.
electronic charting system.
Hmm.
There is a place in My Chart where you can fill in much of this information. It's essentially an advanced directive. It's not the newest one, but it's in there. The only challenge with doing it on there is that it can't be witnessed. So it's not a legal document. It would still be a guide to the staff, but it wouldn't carry the weight of a legal document. And if you are a BB patient and you haven't gotten My Chart, I recommend it. If there are no other questions in the recording section of this, Kate, I'm wondering if we maybe want to stop recording in case someone has a question of a more personal nature that they would like to ask.
Absolutely.